how many of you have attempted fetal echo? Yes, sir. And how many are doing fetal echo regularly? None? And they are on the dais, they are doing it regularly. Devasmita is doing it regularly. And how many of you want to learn it after getting inspired by this evening session so that we can continue with our discussion? Or you are finding it too difficult? But what I think is a very interesting subject to start with. You may be finding it challenging. Take one of your sonologist friend help. Side determination may be a bit difficult, though Dhritaputra tried to explain it. You may try with the doll also. Keep on the mother's side a doll and orient it according to the fetus. It may be at times disappointing as you are finding a good view and then the baby moves and the heart also moves from the picture and you have to start all the thing once again. But these things are very challenging and nice pictures you can bring, and I would request Diptapoto to give you a few more ideas about the transducer, because the best kind of resolution you have in fetal echo. I think you have talked about the curvilinear, you talk about something about the footprint, how much the area should be. You can take up initially the sonologist transducer itself. Then to have a better resolution, you can go for better, higher transducer. What I have found, we can interchange between the cardiac and the sonologist, and they can be a better help. Devdatta, yeah. Not only question, you have to give comments also.
Sir, I have a question, sir. Ventricular dysynchrony, is there any like hypoplastic left heart? I can understand it's like a globular small heart, but ventricular dysynchrony, when can we diagnose? What is the criteria for ventricular dysynchrony?
I don't have any personal experience of diagnosing ventricular dysynchrony in the fetal life. So I won't be able to tell you exactly how to do it. So, but why do you want to know the ventricular dysynchrony first of all in the fetal stage?
Can I tell something? Are you asking about the ventricular rhythm disturbances and all that?
No, the size discrepancy.
Size discrepancy.
Oh, size discrepancy.
Okay.
Sorry. So size discrepancy, you mean that the size of the left ventricle and the right ventricle?
The relative sizes.
Yeah, as I was mentioning that usually both the ventricles are more or less equal in size in the mid trimester, and as the pregnancy advances, the right ventricle becomes slightly bigger than the left ventricle. Now, there may be sometimes a confusion whether the left ventricle is small or whether the right ventricle is big, or is it really small or is it really big. The best thing is to take some parameters, like you can check the size of the AV valves. You can compare with the Z scores. Most of the advanced machine now have inbuilt Z scores. So you can measure the mitral valve Z score and the tricuspid valve annulus Z score. You can take the length of the ventricle, right ventricle and left ventricle compared with the Z score, because every parameter will depend upon the gestational age. So you cannot comment only on the measurement. You have to compare with the Z score value of the normal fetus of that particular gestation.
And even the outlets, basically, the outlets will depict the ventricular disproportion also.
Identify which ventricle is which.
Yeah, I think
for the beginners, because in an adult it is very easy to do. Or a fetus of 2 or 3 months is very easy to do, to differentiate between right and left ventricle. But in fetus, it may be a bit difficult, and segment analysis from the veins, from the arteries, also because there maybe you can think about corrected transposition as she told you.
So ventricular,
it is not only a single point, you have to think about multiple points. So identify which ventricle is which first, then go for the asymmetry.
Exactly.
Yes, sir.
So
That's always a picture, like Ram is Ram and Sam is Sam. So that we have to be keeping in mind actually.
The points are same as we do in any pediatric echocardiography. The two most important things what I will say is to find out the offlets of the AV valves, because the tricuspid valve is slightly apically displaced, and when you look at the crux of the heart, then you will always be able to appreciate the which AV valve is towards the apex and which is distal from the apex. And another is the moderator band, because that will help you to identify the right ventricle. These are the two main parameters what one should check. Then you can look at the smoothness of the ventricular wall and the papillary muscles and all these things. But those are same as we do in pediatric echo. Yes.
Yes, sir, the
absolutely.
connections are also very important, and the which atrium is married to the which ventricle, that is also very important, because the atrium are very much loyal to the ventricle.
In adults, we find that the pulmonary artery is bifurcating.
Yeah,
But in fetus, both of the arteries are trifurcating.
no, sir.
Why I'm saying this?
Sir.
In case of arch aorta, think of the brachiocephalic and the
Okay.
subclavian
Yes,
and
sir.
this.
Yeah.
And in this case, the pulmonary arteries and the ductus,
Yeah.
big size.
Yeah, yeah, sir.
So for the beginners, these things may become difficult. For
Yes, sir.
your experience, so you are not finding the difficulty.
Yes. Thank you, sir.
Devashmita, you showed a very nice case of tricuspid valve dysplasia. And there was one, I think there were two with Epstein's anomaly. Just tell me, what are the differentiating points? What should we look
It's a very
out for?
nice question actually you have put up actually. Many a times we are confused with the right atrial enlargement and we are coordinating with the Epstein's always. But it can be a tricuspid dysplasia. Tricuspid dysplasia is about the normal tricuspid valves actually. Only dysplastic. The valves are dysplastic, that we can think that the thickened valves will be there. But the Epstein's anomaly is about the posteriorly displaced. The tricuspid valve has three leaflets. The posterior leaflets will be totally posteriorly displaced actually. It's almost like very much lengthened right atrium than the
Caudally, the septal and posterior leaflets will be caudally displaced.
yeah. And about the tricuspid regurgitation as well as. The tricuspid regurgitation will suit up to the apex as well as in the Epstein's, but the tricuspid dysplasia will be the in midway
Like
between
a low
actually.
pressure tricuspid regurgitation in Epstein's, and I think dysplasia
Yeah,
will have a
that's
slightly higher pressure. Can we do that? Can we comment on that in an,
Yeah, dysplasia, first of all, usually the valve will be hypoplastic. So if you look at the tricuspid annulus in Epstein, the tricuspid annulus is either normal in size and often it is bigger in size. But in case of dysplastic tricuspid valve, it will be smaller. The annulus is usually smaller, and as you have already mentioned that there will be apical displacement of the septal leaflet and posterior leaflet of tricuspid valve, that you can appreciate. If you have any doubt whether it is a Epstein or a dysplastic tricuspid valve, as I was mentioning, more important to find out the hemodynamics. If there is severe tricuspid regurgitation, right atrium is hugely dilated, that gives a very poor prognosis. Compared to a valve which is morphologically slightly dysplastic, right atrium is not that big, probably the outcome is much better.
I think while describing a tricuspid valve morphology, it is not always important to stamp it as Epstein.
Exactly.
There could be so many variations
Exactly.
of the tricuspid. I think
Yes,
you
sir.
will agree, you have seen so many cases.
Yes, sir.
As your list shows that you have recorded very well them. So tricuspid valve, it is better to describe how is it looking like and what is the actual problem we are having. That
What is the
will help
hemodynamic
surgeon
problem it is causing.
better, and
Yeah.
also help as hemodynamics is okay. It could be stenotic, it could be regurgitant, it could be both stenotic and regurgitant.
Or
but
right
it
obstruction.
may not be displaced. In case of Epstein, displacement is an essential quality. Redundancy is an Epstein. So everything cannot be matching with Epstein. Tricuspid valve has got many variations.
Yes, sir.
Thank you, sir. One quick question, sir. That is, the patients don't come reading the book. So fortunately, when we have omphalocele or gastroschisis, something like this, how do we determine the situs? Because everything is pushed this way and that way. So
Is it okay?
I find it very difficult on those cases.
See, if the stomach is displaced within the say for gastroschisis, you should take the cross-sectional abdomen and see the relative position of the aorta and the IVC compared to the spine, because the aorta and IVC will not be displaced. Okay, so as we do in pediatric echocardiography, we start with the situs, we take a cross-sectional view of the upper abdomen, we see the position of the liver that it is on the right side, and then we look at the where is the aorta and where is the IVC. Aorta will be slightly to the left of the spine and IVC will be slightly anterior and to the right of the spine. That is the normal position. If we find the aorta and IVC in the normal position, then we can assure that the situs is normal.
I think while you were giving an initial talk, you were talking
I have shown
about,
a slide.
Yeah, you have shown it. That stomach bubble and the apex. should be
Relative
on the same
position of
side.
the aorta
But
and IVC.
prior to that, you have to show the sidedness because it could
Laterality.
be situs inversus totalis.
Absolutely, absolutely. So you always start with laterality.
And your statement about the LA position is important, but left atrium is, I think, most easily identified. It is the posteriormost chamber.
And it is, in the fetal life, you can see that it is just in front of the aorta.
In front of the aorta.
Just
so
in front of the
It is
aorta.
intimately related to the aorta.
Exactly.
Aorta is in front,
Exactly.
the ascending aorta, and also on the behind. So it is just on the arch, the LA is there.
Now, it is, as we know that transesophageal echo, the structure which is in front of the TE probe is the left atria,
that is
because
it.
that is just in front of
Same
the
thing is being
esophagus.
maintained.
Same is,
Soumitra, how much time do we have? Because we can
think-
continue with this.
I think
because
we have already exceeded the
the
time. It is
audience may
already,
not be interested.
yeah,
So
we
I
can, we
leave
can.
it in Devdatta. Two Devis are with us regarding this discussion, two Devis. So they will decide when to conclude.
হ্যাঁ স্যার হয়ে গেছে
Okay. Okay, so it's been a lovely evening. Thank you. It has been a great learning experience. Thank you to the organizing committee and the.
আই হ্যাভ কমপ্লিটেড হ্যাঁ স্যার এসে গেছে জাস্ট আমি কুইক করে দেবো স্যার আই ওয়ন্ট ওয়েস্ট আ পাই অফ টাইম অফ এনিওয়ান আই প্রমিস
Thank you to the. We have a very busy day tomorrow. Early day and busy day. So, Devashmita, can we keep it for the next time you're here?
Everyone is
টাইম ওন্ট
hungry.
কাম ফর মি
Yeah. I am sure you'll have lots of interesting cases, add on to them, and we love to hear from you again. And
Show it in the Soros Center.
yes, yes, yes.
Have a look. We'll be having some food and tea and drink.
Not tea, sir,
Absolutely,
dinner and
sir. So thank you, everyone. Thank you to all my seniors, colleagues, and the organizers, everyone. Thank you so
What
much.
I find most gratifying at the end of my lifestyle, I think I am
Sir, wish you a long life. Don't say like that. Sir, wish you a long, long life. Healthy and happy.